I'm delighted to be here because I lived in Florida briefly 10 years ago, organizing nurses in the HCA hospitals. And to my knowledge, there wasn't much of a single payer movement in Florida at that time. So I'm very happy to see such a vibrant group in Florida now. So I'll start. It is frequently said that US healthcare is fragmented, which it certainly is, but our situation is much worse.
This is a Zoom meeting on Medicare for all.
Someone please mute. Thank you.
Thank you. Our situation is much worse than fragmentation. We really must be talking about the takeover of almost the entire system by profiteering corporate healthcare in all its forms. We need to analyze how private equity financiers are aggressively taking over hospitals, doctors' practices, behavioral health providers, ambulances, home care, and much more. We must understand how Medicare is on its way to being completely privatized. And we have to reverse the most recent abuse, which was started by the Trump administration, but is being continued by the Biden administration, which is now called ACO Reach. We have apparently now had a small victory in pushing back ACO Reach, and Corinne is going to talk to you about that. It is good that President Biden has taken a strong stand against the extreme Republican, your dear senator, extreme Republican proposals to cut or end Medicare. But unfortunately, he and most of the Democrats in Congress are not being entirely truthful in saying we will save Medicare. That's because Medicare, as it was intended to be, a universal public program, not profiting anyone, has undergone insidious exploitation by private insurers for years, often with the collaboration of Democratic administrations. While the movement to end ACO Reach is of greater urgency and is therefore the focus of most of us in the anti-Medicare privatization movement, there has been another important expose recently concerning the monumental defects of the so-called Medicare Advantage programs. The Medicare Choice Act in 1997 created Medicare Part C.
Excuse me. Hold it, Marilyn.
Yeah.
Angie or Stefan, would you be able to mute everybody except the speakers? Would that be possible, please?
I've been trying to do it manually, but let me see if I can figure out another better way. Sorry.
Well, while you work on that, Marilyn, continue on. We'll hope there won't be further interruptions.
I know sometimes people's microphones are on. So the Medicare Choice Act in 1997 created Medicare Part C, which was labeled, later on in 2003, it was labeled Medicare Advantage. So in the last 25 years, this program has become a monstrosity, cheating seniors out of the care that they have already paid for through their tax contributions. The former insurance executive turned single payer supporter, Wendell Potter, I hope you're familiar with him, said recently, quote, Medicare Advantage is the biggest transfer of wealth from taxpayers to corporate shareholders in history, unquote. Why are so many Medicare beneficiaries attracted to these defective plans? One activist calls the choice between traditional Medicare and Medicare Advantage a, quote, forced choice, because the Advantage plans are simply cheaper compared to the Medicare Supplement or Medigap plans, which can be bought by some seniors to cover what traditional Medicare doesn't, but which costs about $200 a month. And if you belonged to an Advantage plan and you try to get back into traditional Medicare, in most states, you can be denied a Medigap policy based on any pre-existing conditions you may have. Then, in terms of why people join Medicare Advantage, there's a whole huge role of AARP in pushing their particular Advantage plan with United Healthcare. AARP gets $814 million a year from the Medicare Advantage insurers for using the AARP name and logo. But AARP does not monitor or protest when abuses occur, such as huge numbers of care denials. Now we are seeing unprecedented documentation of the truth about Medicare Advantage plans. This year, those beneficiaries enrolled in so-called Advantage plans will outnumber those who have chosen to be in traditional Medicare. From 2006 until 2022, Medicare Advantage has grown 337% in terms of its enrollment, 337%, compared to enrollment in traditional Medicare, which decreased by 2.9% from 2006 to 2022, according to a study in Health Affairs. Furthermore, Medicare Advantage enrollment is higher among seniors of color than it is among white seniors. Since last fall, numerous mainstream media articles, most importantly, the October 8th New York Times investigation with the title, "The Cash Monster Was Insatiable." That's the title of the article. All these articles have appeared exposing widespread defrauding of the government by many Advantage plans. The New York Times piece discusses how Medicare Advantage plans have cheated the Medicare fund out of $600 billion over the past 10 years. Other articles also all have focused on the issues of fraud, false advertising, denial of necessary care, poor access to choice of doctors, and corruption. They have delved deeply into the epidemic of false and exploitative advertising for Advantage plans, which has been going on for many years. Everybody sees those TV ads, as well as the insurer's practice, which is called upcoding. This was the main topic of the New York Times investigation, upcoding, in which the plans claim submissions to Medicare fund make patients appear sicker than they are, so that the plans can get paid more by the federal government out of the Medicare Trust Fund. In addition to the New York Times, there have been some other media outlets examining Medicare Advantage: CBS News, the Houston Chronicle, the Commonwealth Fund, Axios, and National Public Radio, and those were just last October. Since then, more and more media coverage has appeared. These articles have brought out important facts, such as that Medicare Advantage profits are 30% higher than any other section of the healthcare industry. That 6 out of 7 of the largest insurance companies get most of the revenue from Medicare Advantage plans, and that insurance brokers get double their commission when they refer clients to a Medicare Advantage plan. They get double their commission rather than when they refer someone to traditional Medicare. One of the worst aspects of Medicare Advantage is the denial of necessary care through what is known as prior authorization. Did you know that the insurance companies hire an outside middleman to conduct the prior authorization process? So that's just another layer of bureaucrats taking its cut. Millions of care denials are made each year, causing sick and elderly patients and their families to go through complicated appeals processes. The Health and Human Services Office of the Inspector General published a report last June examining 12 of the Medicare Advantage companies. And it showed that in the year 2019, there were 84,800 care denials for services that Medicare did in fact cover. We may rightly ask what the role of the regulatory agencies and the agencies who are supposed to be protecting our health rights has been. Up until the recent exposés, the Center for Medicare and Medicaid under Health and Human Services has been weak in their oversight, their auditing, their disciplining, and fining Medicare Advantage companies. They have taken years to conduct audits, allowing lengthy appeals by the plans to slow down the audits. But now the scandal around upcoding, the claiming patients are sicker than they really are, has exposed billions of dollars in overpayments by Medicare to the Advantage plans in just the last few years. Think of how all that money could have been used to expand Medicare services as Bernie Sanders proposed for dental, vision, and hearing at least. And what about expanding Medicare coverage to home care for the frail elderly? Now, Center for Medicare and Medicaid is going to go after 4.7 billion of these overpayments, which is only a fraction of the overpayments. They're letting a lot of the overpayments, letting them go, so to speak, not going after them. So we'll see what happens with CMS's efforts to get back that money. Has the upcoding stopped by the insurers? We don't know. And as to the care denials, I'll refer you to today's issue. Wendell Potter has a new newsletter, which is called Healthcare Uncovered, Healthcare Uncovered, and it's on this website called Substack, and you subscribe to it. So just today's newsletter, Wendell covered this question of prior authorization and what's going on with care denials and prior authorization. So there is a response coming from the federal government, but it's way too inadequate. There's a lot of work ahead that we have to do to get Medicare, the kind of Medicare that serves its original purpose and isn't just a conduit for profits to insurers. A review of the Congressional Progressive Caucus website, which I looked at today, shows that they do prioritize. Congressional Progressive Caucus prioritizes, quote, a quick transition away from ACO Reach, which has incentives to restrict care. But the Progressive Caucus doesn't mention the problem of Medicare Advantage, which has the same incentives to restrict care. In January of 2022, a shameful letter was signed by 346 members of Congress to the head of Center for Medicare and Medicaid. It included many of the best liberal Democrats, and they just reinforced their enthusiastic support for Medicare Advantage. In terms of the upcoming fight, our opponents have organized under the name the Center for Medicare Choices, the Center for Medicare Choices. So beware of them. Now, a small yet significant start in Congress is something called the Save Medicare Act, which was introduced by Congress members Pocan of Wisconsin, Khanna of California, and Schakowsky of Illinois. This legislation would prohibit the insurer's use of the term Medicare for those so-called advantage plans, and that would fine them if they use the term Medicare. Although this is a very modest reform, it serves an important educational function since so many in the public are quite confused about what has really happened to Medicare. But as the health economist, Dr. James Kahn, who is a strong supporter of single payer, as he said, fine-tuning Medicare Advantage or just identifying the bad actors is nowhere near enough, because it's the structure of the whole system that is defective. You can see more of Dr. Kahn's thinking in his free newsletter, Health Justice Monitor, excellent newsletter, Health Justice Monitor, which is at healthjusticemonitor@gmail.com. One of the most important activities we can engage in right now is meeting with members of Congress and educating them about the truth about Medicare Advantage. Even the progressives urgently need this education. We have to make opposition to Medicare privatization a litmus test for all Democrats. Despite the mixed results of the midterm election, there's a lot that we can do that does not involve new legislation from the House of Representatives, which is now, as you know, controlled by the Republicans. We can build on the important, there was a Senate Finance Committee report recently issued in November concerning the deceptive advertising of the Medicare Advantage plans. So we could build on that. We can demand more Senate hearings. Bernie Sanders is now in charge of the very powerful Senate Health, Education, and Labor Committee. And so that would be another good venue for public hearings. We can apply pressure specifically to Health and Human Services and Center for Medicare and Medicaid, which have been way too weak since the Biden administration started. There's a lot we can do at the state level, because most states have insurance commissioners, and 11 of the states have elected insurance commissioners. We had a very progressive one in California for a while. So filling this position of insurance commissioner with progressives can be very important. A good website to learn more is protectmedicare.net. Protectmedicare.net. This website makes clear that the only real solution is abolishing Medicare Advantage and replacing it with improved Medicare for all. I also recommend the Health Justice Monitor and the Healthcare Uncovered newsletter by Wendell Potter. I hope everyone will get involved in protecting yourselves and your families through our movement against privatization. And I thank you very much for listening.
Okay, well, Marilyn, thank you so much. I learned from your presentation just now, and I'm very impressed with what Florida is doing. I love the video that you had before. I didn't realize how much you are doing in Florida, because I think you are dealing with some very difficult opposition. So thank you, Florida. So I am coming on to discuss specifically the ACO Reach program, which Marilyn alluded to. It's a program that more and more people are beginning to understand how bad it is, but there's still a lot of education that needs to be done. And I hope that once you go through these slides with me, you'll be equipped to spread the information more about this program and the importance of stopping it altogether. So the ACO Reach program began under Trump with the name of direct contracting entities. And one of the people who started it was Jared Kushner's roommate, who is a big businessman, private contractor. And it is run under the auspices of a small department under CMS called the Centers for Medicare and Medicaid Innovation. The acronym is CMMI, which is a very obscure agency within the big government agency, Health and Human Services, that has the power to implement pilot programs and then scale them up without congressional approval, without any congressional input, because they are considered demonstration projects, which is why they are a low-hanging fruit that we can try to stop altogether. And what has happened is, as Marilyn mentioned, the Medicare Advantage programs have successfully enrolled over 50% of seniors in this country. And so there's still, 48 to 49% of seniors that are still in traditional Medicare, including myself. And so along comes these Wall Street investors, and they go, we can make more money extracting money out of the Medicare Trust Fund. And so they developed this program called ACO Reach. So what is ACO Reach? Well, with traditional Medicare, we have the Medicare Trust Fund, which is this little building that pays directly to providers and hospitals. With Medicare Advantage, you have a middleman that takes money out of the Medicare Trust Fund, and Marilyn exposed how some of this is extracted, is draining the Medicare Trust Fund. And they in turn control how much money goes to providers and hospitals. With the ACO Reach program, we have a whole new layer of investors that create another middleman that they invest in terms of millions and billions of dollars. And this middleman then also extracts money out of the Medicare Trust Fund and distributes it to the providers and hospitals. And these investors expect a very, very big return on their investment. And that is their primary purpose, to get their money and then some back from their investment. They do not have to have anything to do with healthcare. Some of the boards may have maybe one nurse, maybe none. It can be any company that decides they want to make a big profit. And Medicare is one of the best ways to make a profit. And none of the programs that apply for approval from the Center for Medicare and Medicaid Innovation, the CMMI, need approval from Congress. There's no input from Congress. This is all determined by the small agency within the Health and Human Services. So how do these ACO Reach entities make their money? Well, there's three big ways. One of them is to maximize the revenue from Medicare. And Marilyn did discuss upcoding, where each person that's enrolled in the program has a list of diagnoses, and those diagnoses get a certain score. And by making the diagnoses more complicated, those scores go up, and with a higher score, more money is extracted from the Medicare Trust Fund. And remember, this has nothing to do with treating the people. It's just a list of diagnoses. Well, with ACO Reach, let me go back a little. What does ACO Reach stand for? It stands for Accountable Care Organizations Realizing Equity, Access, and Community Health, which sounds just great. I mean, who can be against that? But when you look more closely, these equity incentives actually can encourage these reach middlemen to profiteer from underserved communities. And the way they do that is they get an extra $360 per person from the Medicare Trust Fund, per person that lives in an underserved community. So they scour the underserved communities to try to get people to enroll in ACO Reach, but they don't provide extra care necessarily. And then they also upcode too, just like Medicare Advantage, but now they can also, instead of just using medical diagnoses, they can use what's called social determinants of health. What are social determinants of health? Well, social determinants of health include that are probably maybe even more important sometimes than the actual medical diagnoses. Social determinants of health are things like poverty, exposure to pollutants, lack of transportation, poor nutrition. All of these affect our health. And these social determinants are then stacked up per patient and used as part of the way to increase revenue from the Medicare Trust Fund without providing extra treatment. So it sounds really good, but there is no accountability for these ACO Reach programs to actually provide this improved equity, this improved access, this improved ability to provide for community health. So that's one way that they get money. The second way is to minimize revenue on patient care. And so what they can do is they can actually mandate that physicians see a whole lot more patients per hour, which of course is already difficult at this time when you only have a few minutes to spend with your doctor. They can do things like not repair equipment or cut down on office staff. I don't know how they do these things. I'm sure they figure out other ways to minimize revenue spent on patient care. And of course, this is a big incentive. The profit is a big incentive to cut down on healthcare. And then the other big way that they actually make a lot of money is to enroll more beneficiaries. But unlike Medicare Advantage, where seniors have a pseudo choice of enrolling in Medicare Advantage as individuals, what the ACO Reach entities do is they actually go to primary care physician practices, to the administrators or the head of these practices, which can have anywhere between 10 and 100 physicians working for them. And they convince the physician practice to sign on with the ACO Reach entity. So how do they do that? Well, they promise that there'll be less authorizations and less paperwork, and that then physicians can share in the savings that are generated by minimizing revenue spent on patient care. So this is a really bad incentive and can interfere with a physician's clinical decision-making abilities. For instance, I have seen patients, and sometimes I've said, some patient wants an MRI, for instance, for a headache. Well, there are times that it's definitely appropriate to get an MRI, but a lot of times it isn't. And when I try to explain this to a patient, I make my argument based on hopefully good medical practice, good evidence. However, when the physician starts becoming responsible for the profits of this organization, it can insidiously start affecting the ability of the decisions that are actually made for patient care, which is very unfortunate. So let's go back. The ACO Reach program approaches a primary care organization, convinces them to join, and then that ACO Reach organization has access to all the seniors that are seen in this program, in this practice, who are still on traditional Medicare. And they can then, quote, align, that's what they use, the word, we tend to say assign or swoop in, take all those traditional Medicare seniors and assign them to their own ACO Reach entity without the senior's consent and without their knowledge. This is all done surreptitiously. Interestingly, before the ACO Reach entity was created, it was called Direct Contracting Entity. And the name was changed because of public pressure, because some of their practices were so outrageous, and they continue to be outrageous. But one of the things they started out with was the ability to divide the nation into 13 regions, not all the nation, but parts of the nation. And Tampa, Florida was one of them. And they were allowed to go to Tampa, find out all the seniors that were enrolled in traditional Medicare, and align them into their program without the seniors' consent or knowledge. This created such an outrage, such an uproar, that was one of the reasons direct contracting entities, which we had hoped would be terminated, just changed their name to ACO Reach, and it's not any better, except that they have a different way of enrolling the seniors. So a senior gets aligned or assigned, and eventually they do get a letter that can look like this. Now, Marilyn has heard me say this many times, and so have other people in the audience. If I got a letter like that, it doesn't say I won the lottery. It doesn't say that I owe some money. It just says no action needed. What do I do without reading these multiple paragraphs that are pretty much gobbledygook? I throw it in the garbage. But there are some seniors that are much more careful than I am, and they read the letter and they go, oh my goodness, I am now enrolled in this organization, in this company. So they call, they get a very pleasant voice on the other end, and the senior says, I don't want to be in this program. And the pleasant voice at the other end says, no problem. You have traditional Medicare. you can leave. But what does that mean? It means the only way to opt out of this particular primary care practice that is now affiliated with this ACO Reach program is to change their primary care physician. And if you've had a long-term relationship with your doctor, well, that gets disrupted if you decide to leave. If you are in an underserved area or a rural area where I live, and a practice has been signed up with ACO Reach, there is no place to go. You cannot go unless you leave the area. And as more and more areas of the country, as more and more physician practices are signed up, there's less and less of a choice. And this undermines the traditional Medicare's promise of free choice. Medicare Advantage limits it already, and ACO Reach limits it more, because that is one of the treasures of the traditional Medicare program. We have a choice. With my card, I can go anywhere in the United States to any practice if they accept Medicare, and I can see them. So when the ACO Reach entities are allowed to keep as profit and overhead what they don't spend on services, it's a very dangerous incentive to ration and restrict seniors' care. And once again, these financial incentives do not exist in traditional Medicare. Traditional Medicare is a not-for-profit trust. Let's look at the difference in how much the different programs actually spend on patient care and keep for overhead and profit. If you look at the first pie on the left, you can see with traditional Medicare, it's between 2 and 3% that's spent on administration and overhead, which means 98% is actually spent on patient care. With Medicare Advantage, they're allowed to keep 15% on overhead and profit, which means 85% is spent on care. And with ACO Reach entities, remember those three guys at the top of that graph I showed you? They're allowed to keep between 25 and 40% of the money they invested into overhead and profit. That is a very lucrative deal. And the ways they do it are the ways I showed you already, but there's other ways. And if you go to the CMS website that explains ACO Reach entities, it's very obtuse, it's very complicated, very difficult to understand. And there's lots of ways for upper echelon financiers to figure out how to extract that 40%, besides the ways I just reviewed. One of the ways that I understand they can do it is that to add to the monies that they're trying to extract is if they can keep the first, they can keep 100% of the first 25% that they don't spend on the seniors' healthcare. So for example, if they get $10,000 for a patient that's enrolled in their program, if they only spend $7,500, they get to keep 100% of that $2,500, which I hope makes sense. The rest of that money, $7,500 that's left over, they find other ways to extract, and there are other ways, all sorts of ways, risk corridors, risk adjustment. I mean, just, it's unbelievable, all the different permutations that the ACO Reach entities have figured out how to extract more money from that extra $7,500, not extra, the $7,500 that's left over. Now, Marilyn alluded to how lucrative it is to invest in Medicare, and this is a good graph, I think, that explains it. If you see, investing in Medicare is the blue line, private insurance is the pink line, and Medicaid is the orange line. So I don't know even how companies extract money out of Medicaid. To me, it's like extracting blood out of a stone because it's a limited budget. But Medicare, this is one insurance company that has shown that they can extract $100,000 million, which is worth, I had to look it up, $100 billion of revenue from investing in Medicare. So no wonder so many corporations are trying to get their tentacles into the Medicare trust fund. It's very lucrative. So what happens if Medicare is taken over by both Medicare Advantage and ACO Reach? Well, we may not have a Medicare trust fund because it's predicted by the Congressional Budget Office that the Medicare trust fund may become insolvent by 2026 or 2028. And if we lose our Medicare, we certainly, seniors and people with chronic disabilities who are eligible for Medicare will lose their choice of health and how they want to be treated in terms of health care. One of the most important things that has been made very clear by the woman who runs this small CMMI, which she talked about to a group of physicians from Physicians for a National Health Program, without any remorse, without any concern, is that they want to completely privatize Medicare by 2030, if it remains solvent. And this sentence, which says all Medicare FFS means fee-for-service beneficiaries will be in a care relationship with accountability for quality and total quality and total cost of care by 2030. What that means is we want to totally privatize Medicare by 2030. Now, here's an example of some of the corporations that are involved in Medicare Advantage and in ACO Reach programs. And as you can see, PNHP likes to call them bad actors. And there are a lot of bad actors. Are there any good actors? Probably not. How can there be good actors when you have to extract so much profit from any investment you put in to a public service? So these are examples of some of the big three. Centene has overcharged for prescription drugs. And Centene, by the way, is spreading its tentacles into Europe and has programs in Czechoslovakia, in Spain, in England, where they're trying to privatize the National Health Service. Clover Health, which has offices in Florida, was fined for using marketing materials that misled beneficiaries about their network. In other words, they promised a whole lot of stuff and they didn't deliver. And Advent Health, which also has programs in Florida, promised kickbacks with the money that they got. So all of these corporations have been sued or brought to court by various departments of the government, Department of Justice, investigative, I can't remember the names, but they have been brought to court. Most of them have settled, which means they weren't made culpable. They just had to pay some money back. And remember, the money that they're paying back is nothing compared to the money that they're making. It's just part of their investment. So what happens, oops, I have to turn a light on because I can't read what I'm trying to say. You know, back in 1965, Lyndon Johnson passed the Medicare Act. And there's Truman looking very happy because he wanted a national health insurance program for everyone under his presidency. But Johnson signed it, got it through with his masterful techniques of twisting arms. And unfortunately, he never was able to appreciate it because he died at age 64. But Medicare became a lifeline for people 65 and over and those with certain chronic disabilities. Because before we had Medicare, about half of seniors had absolutely no insurance. And it was never meant to be a golden goose egg or a playground for Wall Street investors. And it's a myth. I mean, these people who are trying to privatize Medicare, they push this idea that inserting a middleman, a private middleman between Medicare and health providers will save money and improve care. And it just makes absolutely no sense. And if middlemen in healthcare really did save money and improve outcomes, the United States wouldn't have the most expensive, dysfunctional, and ineffective healthcare system in the world. And let me just refine that a little. We have excellent medical care for advanced diseases. People come from all over the world, but you gotta have money, and it is not accessible to everyone. So these guys are coming in to try to privatize all of Medicare, and this must be stopped. And the ACO Reach program must be stopped. So, because if Medicare is totally privatized, it's going to be a tragedy, not just for seniors, but for everyone and for generations to come. And the ripple effects will continue on and on. But wait, there's a newsflash. As Marilyn mentioned, because of public outcry, because of what you in Florida have been doing, what we in California have been doing, what people around the nation have been doing, educating, activating, demonstrating. The Medicare Advantage program it hasn't been stopped, but it's been stymied. The woman who runs the CMMI is not, the CMMI department is no longer going to approve further applicants into the ACO Reach program. Currently, there are 132. They cover 2.1 million seniors. So there's still a lot of seniors that are roped into this program, but at least there supposedly won't be more. However, because the goal of CMMI, the people who run CMMI and the people who run CMS, who a lot of them had positions in private insurance before they went through the revolving government door into government practice, do really believe the market can control costs and can improve quality. And they're going to take bits and pieces out of the ACO Reach program that I've referred to, and they will create new programs. So we have to be really, really on alert to watch for new programs that may be coming out. And basically what we need to do is stop the privatization of Medicare altogether and promote a single payer healthcare system. But in the meantime, I know Marilyn had some great ideas for what can be done, and it sounds like Florida is doing your group is doing a tremendous amount already. This is an example of a resolution that some of us have used. There's some permutations, but we've presented them to labor unions, to Democratic central committees, to Board of Supervisors, to cities, to community groups. It's something you can use to bring and have these various groups sign and then deliver to Biden, who can stop the ACO Reach with a stroke, of his pen, because there's no congressional oversight. But at this point, he's not terribly interested in doing that. So we have to continue fighting. We have to continue struggling to stop the privatization of Medicare, because seniors will lose their ability to choose their health care. Healthcare becomes a commodity and not a right. It's already a commodity, becomes more of a commodity. The Medicare Trust Fund will be controlled by private corporations. And basically it's a threat to our democracy, because when corporations dominate our healthcare, it concentrates enormous political power in the hands of the very few at the expense of the many, and it involves our healthcare. So we will be very, very vulnerable. So basically, as we all know in this group, Medicare is not for sale, and we need Medicare for all from birth till the end of life for every resident in every state and in the nation, because as long as there is no Medicare for all that's nonprofit, corporations will very much continue to try to privatize and destroy our public trust. So we can start with ending the ACO Reach program. And this is something that just reviews everything I've said, and I'm not going to go into it because hopefully you'll remember some of it. But I love this poster: Medicare, don't privatize it, supersize it. We need an improved Medicare for all. And what does that mean? Everybody in, nobody out. And that's the end of my talk.